Hello everyone, hope you're all doing good. In this video, we are going to discuss about secondary PPH. So in the first video itself, you'd have known what is the definition for secondary PPH. So any excessive bleeding that is happening after delivery from 24 hours after delivery till 12 weeks is known as secondary PPH. Clear? So in secondary PPH, most of the times 95% of them will be presenting within 1 month after delivery, and a person with history of secondary PPH is going to have a recurrence rate of 20 to 25% in the successive pregnancies also. Clear? Now we'll see what is the etiology. Etiology most commonly involves uterine infections, that will be endometritis otherwise, right? So what are the causes for endometritis? They can include cesarean section or PROM, or when there was a history of prolonged labor. And most important cause of secondary PPH will be retained placental fragments or tissue, and another causes there is abnormal involution of the placental site. What happens means there is inadequate closure and sloughing of the spiral arteries at the site of placental attachment. Clear? And another cause may include placental abnormalities, that may include placenta accreta, intrita, perfreta, etc. Then secondary PPH can be expected in a case of gestational trophoblastic disease, or when the patient has a history of bleeding disorders like hemophilia or von Willebrand's disease. Clear? Right. And sometimes when there was a lower genital tract trauma. Now what are the causes of this? Suppose already during delivery itself there was a genital tract trauma which was missed. So they can be vaginal lacerations or even hematomas, right? That was missed to manage. And sometimes this is also another important cause. There can be infection of the episiotomy wound site that can break down and can result in vaginal bleeding. Yes? Then in some cases there can be vascular abnormalities as well, okay, like arteriovenous malformation or pseudoaneurysms of the arteries, right? Then in some cases there can be bleeding due to leiomyomas or cesarean section, scar dehiscence, or any injury during surgery, right? And last but not the least, secondary PPH can also occur due to cervical carcinoma. Clear? Now we'll see how they will be clinically presenting. So clinical presentation here it will be different, because in primary presentation we will be having a gush of blood that will be lost on the table itself, okay, or within the observation period, and will be able to see the signs of hypovolemia in the patient, right? But here how the patient will be presenting is, they will be usually presenting with the spotting on and off, okay. Sometimes they can even can give a history of gush of fresh blood, and very rarely, that is say in 10% of the cases, there can be massive hemorrhage also with shock features. Clear? So what are the features of shock? There can be reduced urine output or excessive thirst, dizziness, altered mental status, and you have to know the signs of infection also that the women can present. They can present with fever, and because of endometritis there can be lower abdominal pain, or there can be foul smelling lochia also. Clear? Right. Now, we will see the examination findings. So, on examination of the women presenting with such features, when you do a general examination itself, you will be able to find out the signs of hypovolemia and shock. That is, you will be able to find tachycardia, hypotension, tachypnea. There can be weak peripheral pulses or delayed capillary refilling time, or most importantly pallor, sorry for forgetting this, and then she can also present with altered mental status. And don't ever forget to think about the signs of coagulopathy also, right? So, she may present with petechiae, bruises, or even uterine enlargement, because there will be bleeding that will be happening inside the myometrium, right? Now, what you have to do is, you have to do a bimanual examination to assess the bogginess and tenderness of the uterus. You have to do a perspectrum examination and a pervaginal examination as well. You have to know what is the current state of bleeding. Is it bleeding still now, and if it is an active bleeding or not, okay? And you have to check if there is any hematoma or any lacerations or tears or even a foul smelling lochia. Now, when you find this foul smelling lochia, immediately you have to take a high vaginal swab also, okay, to know what kind of infection is present. That will be sent for culture, okay? Yes. Now, what are the other investigations you want to send for the patient simultaneously while doing examination? You have to send a full blood count, you have to send a coagulation profile, also do CRP if there are signs of infection, okay, you have to rule out sepsis, also blood cultures, and you need to do HCG also. Why HCG means? I already told you, in gestational trophoblastic disease there can be chances of secondary BPH. So, in that cases you have to rule out choriocarcinoma, okay. So, for that purpose, or you can even assess retained products of conception if there was a curettage done for any kind of abortion, or there can be chances of new pregnancy also, okay, that has been going for miscarriage or something like that, okay, right. Now, what are the USG features? USG features are generally non-specific in endometritis. So, what you will have is there will be thickening of endometrium, or there can be a heterogeneous myometrium, there can be intracavitary debris or fluid or gas inside the cavity of the uterus. Sometimes infected placental tissue can also be found, and hematoma can also be there. Okay, so these are some of the signs that are non-specific in endometritis. Then you have to check for retained products of conception also in ultrasonogram. So, you will be able to see solid echogenic intracavitary mass that extends to the endometrium. Clear? So, that will be a echogenic intracavitary mass. Clear? Right. And the next one is about the uterine arteriovenous malformations. You will be having presence of tubular hypoechogenic structure in the myometrium, right? And if you see, these are nothing but the vessels that are having low resistance but high velocity flow. Clear? Yes. And the next one is pseudo aneurysms. Pseudo aneurysms means there will be pulsating anechoic or hypoechoic structure that will be seen in the ultrasonogram. Clear? Right. Now, let us see how we will be managing the secondary BPH. So, management generally depends upon the status of the patient. Suppose if it is an unstable condition, then you have to transfer immediately to your tertiary care center. You have to get access to 2 IV lines before shifting itself. Then definitely have to give oxygen supply and supplement crystalloid solutions to the secured IV lines. If possible, blood transfusion can also be started, right? Okay. And what about the medications that can be helpful in controlling secondary BPH? As we have already seen, Uterotonics like oxytocin, symptometrin, etc. Yes, you can also use tranexamic acid, and definitely since endometritis can also be associated, you have to start them on antibiotics like ampicillin, okay, or clindamycin if there is an allergy for penicillin group, and then you have to cover them with metronidazole, also gentamicin. Clear? Right. And the next mode of management is surgical methods. So, surgical procedures include, if there is retained product of conception, you have to go for evacuation of retained products. Then you can even try uterine compression sutures or stepwise devascularization. And rarely, very rarely, hysterectomy may also be needed. Okay. And in case of von Willebrand's factor, you have to refer them to a hematologist and you have to supplement them with clotting factor concentrates. Sometimes you can even do a radiological intervention like bilateral uterine artery embolization and selective artery embolization can also be tried. Clear? So, yes, with this we are completing our discussion on secondary BPH. Keep learning and keep going until we meet in the next video. Take care. Bye bye.